really this work all came about following the great work done by Jürgen Lieberman, and really it was when I was reading this paper just out last year and looking at his work where he had shown that the one-step warming protocol compared to the multi-step warming protocol that's pretty much standard across the industry, showed no difference in terms of clinical pregnancy rates, implantation rates, and embryo survival rates in his lab. And it was following on from this work that I wanted to look at how we could hopefully replicate this. And this work actually is very groundbreaking. So I will presently show the data from the work that we've done in Australia. And essentially the rapid warming protocol is, as documented in the paper there, it is using the 1 molar solution for 1 minute. And this compares to the multi-step stage of warming that uses the 1 molar, the 0.5 molar, and then the 2 MOPS washes there, which comprises of a length of time of actually 14 minutes. And so the introduction of this rapid warming protocol helps to increase the clinic efficiency by cutting down the time of the embryologists to actually perform the warming. And I think we're all experiencing the same challenges where we are getting busier, it's harder to get staff, the demands on the laboratory fluctuate day to day, and you can see that anything that gives us a bit more time in our day without compromising outcomes is absolutely welcomed by everybody. But we want to make sure that those outcomes are preserved. There's no point doing something faster and saving time if our patients are suffering as a result. So we wanted to make sure that there was safety and that the data supported us adopting this new warming protocol. So we focused not just on the good prognosis patients, we focused on our whole patient cohort and embryos that perhaps might be less than ideal in a clinical setting. So we just wanted to make sure that there wasn't any subgroups of patients that maybe didn't do as well under this rapid warming protocol.
Yeah.
So here is the data set. We included 3 of our clinics. And so we had an initial 1,526 patients. We had to exclude some because there was some missing data. And we excluded the grade 3 embryos because we didn't have that in both arms of the study. And so we divided the data into mainly 2 sets, and they were the embryos that were warmed by the conventional or the slow warming protocol, and those that were warmed under the fast 1 minute protocol. And both sets of embryos were vitrified under the same protocol, so that there was no difference in that stage. But we also then went on to look at the difference between the grades of embryos. And you can see we've got significant numbers in both arms of that study here. As I said, we weren't selecting a particular patient population, so you can see that the spread of the ages was equal in the 2 groups, whether they were slowly warmed or in the fast protocol there. And this is a breakdown of the results. You can see the 2 populations were very, very similar in terms of numbers, in terms of patient age. We also looked at male age, the sperm parameters, the number of embryos, the number of top quality embryos. Majority of patients in both arms of the study had a single embryo transfer. In our clinics, we have a very low ICSI rate, only around sort of 35% of our patients have ICSI, and they are male factor patients. So that was important to break down those patients separately to see how their outcomes were, and I'll show those results in the subsequent slides. And you can see the majority of our patients had a natural cycle FET regime when they had an embryo transferred. And just in the bottom here, you can see how we have graded the embryos between grade 1 being the top quality, and there's a corresponding Gardner grading system that would relate to those embryos, and the grade 2 embryos are essentially anything with a B in the Gardner score there. So we use the generalized predictive model to account for the non-linear effects of age on outcomes and adjust for the covariates like embryo quality, number of transferred blastocysts, and accounting for repeat transfers to patients. So you can see here between the two groups, the slow warming and the fast warming did appear to actually respond differently in this model, although the survival rates were very similar at 98.6% in the slow warming and 98.4% in the fast warming. And if we go to the next slide, you can again see here that the groups showed a significant nonlinear interaction between the age of the patient and the pregnancy probability. And this indicates that the age affects outcomes are different depending on the vitrification strategy. So we've seen here that whilst the overall survival is similar, there is a different age-dependent effect on the between the two different warming protocols. So to have a look at this nonlinear interaction, we chose to look at some of the age representatives of the different age groups. And in the top section of the data here, you can see the breakdown by age, and this is by the age categories. And you can see here how the slow and the fast are comparing across those age groups. And you can see there that there is no significant difference. So that the odds of pregnancies between these different group categories are comparable. So if we then look at embryo quality, remembering that we've got the grade 2 and grade 1 embryos between the different warming protocols, you can see there that although grade 1s we'd expect to do better than grade 2s, there was no difference between the two warming protocols. And again, we then looked at stage of vitrification, whether they were vitrified on day 5 or day 6. Obviously, it's well known that day 6 blastocyst development are going to do poorer than day 5. But when we compared the two protocols between the slower warming and the fast warming, again, we saw no difference. If we were to break down our patients further and to compare our ICSI created embryos with our IVF created embryos, remembering that these ICSI patients are male factor patients, you would expect that perhaps the embryo development and the subsequent outcomes for our ICSI patients would be poorer compared to the IVFs, and we do see that. But when we compare between the protocols, we found no difference between ICSI and IVF created embryos based on warming protocol. So I guess really in conclusion, across this group of 905 embryos, we found no difference in terms of blastocyst survival upon warming, implantation rates and clinical pregnancy rates. And this was a poster that was presented earlier this year at ASRM, and you can see obviously that we were able to maintain high pregnancy rates moving towards the single one-step, 1 minute, 1 molar warming solution across our 3 labs. So not only were we able to save significant time and streamline our efficiency in our laboratories, but we were able to maintain high clinical pregnancy rates for our patients, which is ultimately our aim. So we're super excited that we were able to replicate the work that's been done, and I guess it's been one of the most significant changes that we've been able to make in our laboratories in recent times. So I'm happy to take any questions that you may have and have a chat one-on-one. Thank you.